Okay, so let's get started. So, the renal system. Renal. So, important things to tell you about the renal system. Some of it is that, what do you think of when you think about the renal system? Pee. And what I want you to think about when you think about the renal system is not pee, but is the fact that what does the kidneys actually really do? Regulate and filter and actually reabsorb a whole lot more than it actually excretes. So that's what I want you to think about. So there's your anatomy review right there. Okay. All right, good. And so it does, we do form urine, and it helps us excrete waste products and all that. But it's really important for regulation of electrolytes, acid-base balance, control of water balance, control of blood pressure, and renal clearance. Regulation of blood cell production, synthesis of vitamin D to active form, secretion, prostaglandins, regulation of calcium phosphorus balance, activates growth hormone. And I list all those because, especially when we start talking about the kidneys not working well, and you think about any of your patients that you've ever taken care of that are on dialysis, you realize that they get really sick. They end up with anemia, they end up with osteoporosis, they end up with calcium phosphorus imbalances, they end up with problems with maintaining their blood pressure, hypertension, they have fluid balance issues like fluid overload, and it's all because their kidneys don't work. And so we're not going to get extraordinarily far into renal failure, but it's sort of hard not to bridge into that a little bit because it's a complication of almost everything we talk about. So you have to be aware of it. And so just kind of keep that in the back of your mind. So I was telling you that the kidney's main function is to regulate and to control electrolytes and fluid. And so basically realize that it filters 180 liters of filtrate. So of fluid, electrolytes, we call that filtrate a day. And then only one small percentage of that becomes urine. So a very teeny tiny amount of that 180 milliliters, or 180 liters. Let's see. Not going to say anything there. So, well, I want to spend a second here because we know that the kidneys play a huge role in the regulation of our electrolyte balance. Specifically, what I want to dwell on a second is sodium, because that one we're going to talk about when we get to fluid and, I keep saying fluid and electrolytes, but electrolytes that we, because students tend to get really confused when we talk about whether the kidneys are excreting or secreting. Like if the kidneys are excreting, or are we holding on to stuff, or are we getting rid of stuff, or because they are confusing the terms of secrete, which is what what glands do, right? We secrete hormones. But when we say that the kidneys are excreting something, we're like getting rid of it, right? It's leaving the body and we don't have as much of it anymore. And so that's something that tends to throw students off a lot when we're talking about the balance of electrolytes. So something just to kind of keep in the back of your mind when you're reading about electrolyte balance. So like here we're talking about sodium, and y'all remember that sodium and water follow each other. Especially if you've had high salt meals and can't get your rings off the next day. So we know that if we excrete more sodium, then water will follow that, and we're going to be dehydrated. But if we are retaining more sodium, water will be retained also, and will retain fluid. So you eat a high salt meal, we retain that sodium, retain the water. Our kidneys will eventually be able to excrete that. But it just kind of, our kidneys are have to kind of work on balancing all that out. Oops. Oh, there you go. Water follows salt. What is the hormones that help balance out our salt? ADH or aldosterone. And where is aldosterone secreted from? Yeah, the adrenal cortex. All right. There was a few, y'all said it, and it was kind of adrenal cortex. Good. And what tells the adrenal cortex to secrete aldosterone? Angiotensin II. Good. Now, so ultimately it is Ren, further down our RAS line. Now, this controls our sodium balance. And then we say water follows. But what controls our fluid balance? What hormone controls our fluid balance? ADH, right? I have a blue marker, and that sounds more appropriate for that. So ADH, or antidiuretic hormone, it actually controls our water balance. So sometimes students get mixed up because they think aldosterone controls water, but we say it controls water a lot because technically water follows salt, but really aldosterone controls our salt balance by controlling what the kidneys do with salt, get rid of it or keep it. But ADH is what's controlling our water balance. And there you go, what we just said. Now, we know that most of the water that we ingest is lost through urine, but we know that some of it is lost elsewhere. Let's see. There is, whenever we're looking at urinalysis, or whenever we're even just looking at urine, like say we're looking at urine because that's what we do as nurses, one of our jobs, right? I mean, I can tell just by looking at someone's urine if someone is hydrated or not hydrated, right? But you can tell, and you can tell that by the color. How else can you tell? Smell, right? So you can tell by the smell, and you can tell by the color, because the concentration. And that, what we're referring to, is the osmolality. And that's how concentrated the urine is. And so the more concentrated, the higher number of particulates, that's the higher osmolality. And the more dilute, that's lower osmolality. And that's going to be reflected also on your urinalysis, which y'all were getting whenever you did your big care plan for your patient. For some of your patients who had urinalysis, that was one of the things you would look at. You see down there at the bottom that a normal urine molality is 300 to 1100. And we said that a low was dilute and a high was concentrated. So a low is 300, less than 300, and high is 1100. Let's see. Also, glucose and protein, those are these active molecules that are pulling water, right, to and from. And we talked about that when we talked about like DKA and HHNS, specifically with glucose. So we talk AMP. Are you good with understanding how water is drawn to glucose and drawn to protein? Yeah? Okay. So I won't go into much of that. Specific gravity. I want to come back to this because I should have and I didn't get a chance to pull up. I've got a really good cartoon actually that I'm going to pull up for specific gravity. But it's another part of our UA that we look at that helps us decide how, essentially kind of helps us decide how concentrated our urine is. It kind of measures the kidney's ability to concentrate urine. And so if someone's specific gravity is low, it helps us. Usually someone with low specific gravity's got like kidney damage because of kidney failure, or it might be diabetes insipidus. I don't know if y'all have heard of diabetes insipidus before. It's that type of diabetes that's not diabetes mellitus, the type that we're used to with the high blood sugar, but it's where they're peeing tons and tons and tons of non-concentrated urine. Y'all learn about it when you get to Adult Health 3 when we talk about the pituitary gland. So they have low specific gravity. One way that I like to remember it, because this is a number that you just have to remember. But both of them start with 10, right? 10, which is 1.0, 1.0. But then it's 10 and 25 after that. So 1.0, 1.0, and then 10, 25. I don't know, it's dumb, but.
Are you recording this?
Yeah. So, and then I have a, like I said, dumb cartoon that will actually help you remember it when I pull it up in a bit. And then high specific gravity, so things with high specific gravity, those are things that have said this is, the kidney's ability to concentrate urine. So things like whenever you lose a lot of fluid, so if you're really dehydrated or if you have diabetes mellitus, so have a whole lot of like sugar in your blood, that would cause you to have a high specific gravity. So you could see that on a urinalysis. Renal clearance, so this is one of those things that we talked about with creatinine. Creatinine, who are we talking about with creatinine? Who was I talking about with creatinine? You're not going to admit it, whoever it was. Maybe it was you. Creatine to creatinine.
I think last week.
Yeah, something about with your patient.
They had a high.
Yeah, high creatinine.
Because he had possible stroke.
So, so creatine is that muscle. You've got skeletal muscle will break down, and really the only way that your body can get rid of it is kind of directly through your kidneys. And so we can see how well your kidneys are working by measuring your creatinine in your bloodstream, and then this is another way through your creatinine clearance. And so,
So creatine is the skeletal muscle. That's a protein but then creatinine
is it has to be metabolically changed.
Okay.
To creatinine.
And the kidneys do not do it's done elsewhere.
Elsewhere.
And then it's filtered. Okay.
Mm-hmm. Yep. And so, so it's a good measure, like it says, of glomerular filtration rate. Now, what is a normal glomerular filtration rate?
60.
What do you say?
60.
So 60 is an okay one. 60 is like the minimum we're like okay with. What we would prefer it to be is like closer to 100. That would be a normal. And what are we measuring actually?
How much fluid per minute?
Mm-hmm. So it's milliliters per minute. So milliliters per minute of fluid. And so 60 we would be okay with. That would be considered like within a normal limit, but once we start hitting below that, that's when we're talking about, there's some sort of kidney failure, whether it's acute or chronic. We'll discuss more in depth at a later time. Now, some of those things we were talking about there were in a urinalysis. So someone pees in a cup, and you're going to see specific gravity, you'll see osmolality, you'll see color, clarity, all of those things. The other thing, white blood cells, which there's some information as far as that in your book, as far as how really there shouldn't be many white blood cells in your urine. Once you start seeing white blood cells in blood and all that, what is probably going on? Yeah, you have a UTI. So at that point, they're going to send your urine off for culture sensitivity. So now think microbiology, where they get some of your urine and they smear it on a petri dish, and they stick it in an incubator, and they watch it grow. And they've got the little patches of antibiotic, right? And they're waiting to see like what it's sensitive to. And this is so they can try to get you on the best antibiotic for whatever bacteria you have. Another diagnostic, because you can tell I'm just kind of flowing through the diagnostic things here that we sometimes have to do with urine. This is, I don't know, weirdly satisfying in a nurse way. When you have someone who has a kidney stone. Any of y'all had a kidney stone before? It's like the worst thing ever from what I understand. But we need to catch the kidney stone, because kidney stones can be multiple different things can cause kidney stones. And we need to figure out what kind of kidney stone it is, because depending upon what kind of kidney stone it is, we need to direct the patient as to what they need to avoid or what they need to start doing to help prevent more kidney stones from happening. So we need to catch the kidney stones. So we strain their urine. Like I said, it's weirdly satisfying. It's like a scavenger hunt. Like, did you get it? No, I didn't get it this time. Let's try again next time. So it's a filter. It looks like a funnel, but the bottom of it, just depending upon where you work, but the bottom of it is like a coffee filter, I guess. And you're straining their urine every time they pee. You catch every single drop of urine, you strain it, and are looking for, sediment. Sometimes it's sediment, depending upon the size of their stone. Sometimes it's a big old stone,
I had a guy one time. I went to get him for a CAT scan, and he was for like pain, whatever else. Well, so I go in there to get him. He's like, "Yeah," he goes, "I already know I have stones." And he goes, "Click, click, 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 click." He had a whole bottle of stones. I was like, "Thank you."
All right.
Okay.
Okay. Thanks a lot.
Yeah, I was like, "Oh, that's fancy."
And you're keeping them, I see.
We had a stone like this big. I don't know if it was, I think it was a bladder stone or whatever, but it was like, she brought it to class. It was like this big. And like a weird pyramidal, no, it was like a little pyramid.
It wasn't in the kidneys, it was both, because it was like...
They can be like really nasty looking. Really nasty looking.
Yeah, there's something.
Now, different tests we can do. Looking at the kidneys. One of the ones that they will do is called a, one of the things they'll do is called a KUB, which is, I just remember as a new nurse going, they're going to do a KUB. That sounds really, really fancy. And it's just an x-ray of the kidneys, ureters, and bladder. Yeah, that's what it is. It's an x-ray. But it sounded really fancy because it's called a KUB. So what do you think they're looking for when they do a KUB?
Size.
Size of what?
Kidney. I mean, size of kidneys.
Because what do you think?
Detect stones.
What do you think? But for X-ray, so thinking just like, you know.
The abnormalities, like
But-
structural.
Yeah, I mean structural abnormalities. I mean, because think like on X-ray, big, you know. Remember, like X-ray sees
Just
bone.
it's white.
So if it's calcium, it should be a stone.
Had to be a pretty big A stone.
And fluid is.
We don't have that stone.
Yeah. Yeah. So sometimes you could see masses, like if there was if it was, but it can
Normal structure, like, can you see that at all with an X-ray? Like if it's not normal
like what kind of.
structure, I don't know, like a kidney
No.
margin of one.
Caitlin's sitting over here, she's like, answer the question, Jennifer.
I know.
No, I'm not.
I'm about. No. What kind of
I don't
structure?
know, just like, I don't know, any sort of, like, if the bladder, if it's, I don't know, if it's just found a normal structure of the bladder, then the X-ray shows that.
Yeah.
Yeah, I was like, I don't know, I'm going off the bladder. But yeah, like if the bladder's not, like if it's not structured correctly, or if the ureter is missing, or I don't know, can the X-ray show that? I don't know, what if it's like clamped or something?
Like you
Or
can
blocked.
see,
Or something.
If there's
Get an
like
X-ray.
distended,
Okay.
distension.
And see if there's
Distended
little
bladder.
things in the bladder.
Mm-hmm.
you can see if there's
What I'll-
air fluid levels in the bladder.
Mhm.
You don't really see ureters because ureters are so small
Teeny
unless
tiny.
they're like huge. But you can see kidney position.
Which is a good, in kidney position is a good one. For,
Because I mean, so you can
If it's
see
just-
stones if they're large enough, but they have to be like pretty massive to be able to see them. But a lot of it is just like air fluid levels, and then the bladder, and then the kidneys being able to see like size,
because
position.
hydronephrosis would be one of.
Yeah, so you can see that. You really really CT is going to be the best option for seeing like renal pelvis.
If it's actual.
Yeah. And you can
It's
see.
kind of just a quick.
Yeah. Snapshot.
Now IVP, and CT, MRI, they're going to be looking more for our detailed, detailed issues with our kidney stones and infections, like hydronephrosis or anything like that. Tumors. So you're going to have to go into something more detailed, most likely one of these other things. If you need a quick snapshot, they might do the x-ray, but otherwise they're going to have to go into something a little bit more.
Like IVPs are really good for seeing if they don't do a CT or MRI, but an IVP will show if the stone is actually blocking a ureter to find like positional and whether or not like you've got ureter distension, and to know if you've even got flow, and that may be causing also like hydronephrosis, your renal pelvis is, enlarging, that sort of thing.
And then ultrasound, we've got, Ultrasound, I won't say a whole lot, but they can do ultrasound at times. We won't say a whole lot about that. Cystoscopy. Cystoscopy I'll say something about because they do have times have to go in and look. When we do cystoscopy, what are they looking at? Like it's a scope, right? So oscopy. So we're looking at what is the camera actually visualizing? The inside, right, of the bladder. So a lot of times this might be how they can do a biopsy. That might be a good way to do that. They've got a few things about post-procedure. Let's see. I won't spend a ton of time there. Lots of good stuff you can read. Okay. Now, let's move on to our disorders. So, disorders of the urinary tract. So, start here with cystitis and move on to our different obstructions. So,
Isn't cystitis adult health 3? I read in the notes underneath it was like, it's adult health 3.
Adult health too, it says.
But then I was confused because I was reading it as urinary tract. Never mind.
Oh.
It says
Because in the notes on the PowerPoint underneath it says, never mind.
There might be some,
It just says we'll focus on the obstructions of it
no.
Sorry.
And it's okay. I've probably taken that out because, no, I talk about it. Yeah. You're like, what? Okay, so cystitis is itis, so everyone's going to know that's inflammation, but what's the inflammation of? Don't say the cyst. Okay, good. Bladder. So inflammation of the bladder. And so it is most frequently a problem with our women because they have a short urethra. And so as nurses, we've got to think about how we're going to teach, do a lot of patient teaching here, okay? So, I mean, there's obviously patient teaching we've got to do for men who have cystitis, but we, you know, a lot of patient teaching directed towards women, like front to back. And this can be very problematic in some women who are larger, so think about that. Elderly women who have a harder time reaching, right? So definitely can be a bigger problem in like the elderly because they're maybe incontinent or like difficulty with mobility. So, you know, with incontinent patients, we've got to keep them clean and dry. This kind of goes back to the idea, like whenever I told some of y'all, you know, with my kids, especially when they were in diapers, you know, you ask how many diapers they go through a day. Well, it's however many times I decide to change them, because diapers are really absorbent. Yeah, it gets to the point where it's like, oh, they're only sort of wet, right? Those diapers are expensive. I have twins, so you know, you kind of think about that, and so. Think about like your elderly patients who might not, depending upon the type of care they're having, like how many times a day are they getting changed? They're not voiding only twice a day. Maybe they're only getting changed twice a day. And are they sitting in? What are they sitting in? And especially elderly women, if they have pelvic floor dysfunction, if they're wearing incontinent pads, are they just wearing the same pad so they don't have to change it because of the expense or whatever? So that's where you start, the increase of these bladder infections start getting higher and higher because of the incontinence. And what is the most common type of bacteria that causes E. coli? And we know why here. Because easy caused there. Now, I have, let me see. I have a little bit more that I want to say about that before I move on. Ooh, I printed it out. Let's see if I can find where it went. That's the key. Find where I put it. So y'all did your discussion post or discussion case study on talking about the different types of antibiotics, right? Yes.
Kind of back to something you were just saying.
Uh-huh.
For the overweight or elderly patients that cannot wipe effectively,
Mm-hmm.
you said think about it. I have been thinking about it and don't have a solution.
Ooh, that's good. Thank you, Ansel. I appreciate that. What do y'all want to? What do you think?
Could we do like the whole Roman stick method?
What's the Roman stick?
Like where the Romans used to have the washcloth on the end of the stick and they dip it in the bucket and stick it back there and scrub
Oh.
themselves.
So that's a
And then
possibility.
they pass it on to the next person.
That's a possibility. No, that we have to stop. Draw the line there.
When I was a kid, we had a neighbor that had, when they built their house, they had 2 potties in their house, and one of them shot water up.
A bidet?
A bidet.
A bidet.
A bidet. How come we don't have that in the hospitals?
We had so European are very much more bidet friendly than Americans. Americans, we just use dry paper stuff. So one thing, the wiping from back to front is very common. So, and that's because it's just like physically easier for them to do that. So if the only thing they can do is wipe from back to front, we could suggest that they use 2 pieces of paper, one to wipe the back and one to wipe the front. Front.
What about like butt wipes, basically? You know, like just to clean the area really good. So flushable wipes. Yeah, like flushable wipes.
Like so flushable wipes instead of.
I mean.
Well, the whole thing is you don't want to drag the
Yeah.
like feces up into the vagina area.
Yeah.
So like as long as you like, I probably what would be ideal is to use something to wipe the something to wipe, like probably
Just to
like
clean better, I guess. Is what
clean
I'm saying.
better.
I understand like going from front to back, like they could consciously
mm-hmm.
hit the front and then go from front to back, I guess, if that makes sense.
Consciously say that again.
I mean, like
So-
think, like they think about it before.
Yes.
While they're doing it.
Wait a
so,
second.
Yeah.
Yes, I think it's like education that they are cleaning the back and then they can clean the front.
Mm-hmm.
But some women don't know
Yeah.
that they're, dragging feces up into there, and that's why they continuously get recurrent infections. Yeah. Now, but yes, I was going to spend some more time on this, but I appreciate the thought process there, because you're right. I just said think about it. That was not enough thought. We never resolved that. So y'all's question this week was to discuss about the different antibiotics, right? Mm-hmm. How was that?
Okay, so was it the different antibiotics used for UTI or all the classes of it? Because that is a numerous.
Yeah, so
There's lots of
There's so many
antibiotics.
antibiotics.
There's lots.
I went back to the ATI pharmacology book, and it kind of split it up into what they do and what they target specifically. So there are some that target bacterial cell walls specifically, and then some that target the protein synthesis in bacteria. And then there's 2 that work best for UTI. And that was the fluoroquinolones and the sulfonylurea.
But then there's
Sulfonamide.
so many other different classes that are, I mean, you just can't, you have to have a whole textbook of antibiotic, basically, classes, I feel like. I mean, even in a different pharmacology book.
Well,
There's so many.
There are like 7
There's main classes, yeah, then there's like random ones.
well, but focusing on the 7 main classes, because you don't want to go down the rabbit trails. Because, correct.
I've been there.
The rabbit trails can get very. So I think, yes, I think that is a good approach.
I didn't even think about going to ATI.
Yeah, because it was just like very ATI products.
I know, when she said that, I was like,
Oh, smarty pants. So, okay, so let's talk about the fluoroquinolones. Let's talk about the fluoroquinolones. Because if we have a really great discussion right now, maybe I won't make you review your friends.
oh yeah.
Oh my gosh, everyone perked up. Oh my gosh. Okay. Hello. Okay, so tell me about fluoroquinolones. So fluoroquinolones do what? They mess with your muscles for sure. We talked about that.
They put you on the floor. That's how I remember.
Ooh, they put you on the floor.
Can't they cause blood sugar swings though?
They can cause so many different problems for sure. Okay.
Also cause arrhythmias, which is why you should
I know whatever.
O-N-E.
I was so close. You have to admit that was pretty impressive. Okay, so this is our fluoxetins, right? Levofloxacin is one. That's a good prototype one, which is Levaquin. Now, what did you say in general that the action of it is?
Inhibits DNA synthesis.
Inhibits what?
DNA.
DNA synthesis. Inhibits DNA synthesis. Okay. So, now, it is really good for things like UTIs and respiratory tract infections, but it's got big time side effects. So, concerning for when someone's got a UTI, right, that we're going to give them something that's got all these big time side effects. So that's something that we have to consider. Because they have a UTI, which is not necessarily life-threatening unless it turns into urosepsis. But then they could end up, they could end up with urosepsis. So is this a first-line treatment? Not necessarily, yeah.
Can't fluoroquinolones also cause like serious nerve damage? Have they like done studies on that?
So it's got a,
Something with the synapses not communicating correctly?
it's, the big black box warning for this is tendon rupture, actually.
Oh, tendon rupture?
Specifically Achilles tendon rupture.
Oh my gosh.
That's, and then it's C. diff.
I'll take the
Yeah, and then there's, what else did we say? What else did we talk about? You and I had long fluoroquinolone conversations yesterday. Oh, yeah.
When I was reading
So again, what else?
when I was reading
What of
the
it?
farm book, it said that those were like preferred thing for UTIs.
Yeah.
They
So
are,
does it change?
they are, they're a good drug. They kill all sorts of good bacteria, but they have lots of side effects.
Yeah. In the pharmacology book, it said that they had minimal side effects. They didn't have that much.
That's wrong.
Yeah. Like the only CNS
Seizures,
things were
yeah.
like dizziness and headache. And seizures.
Also, so in the ATI book, it says to use with caution in patients that had any kind of cardiac problems.
Cardiac or kidney disease.
And
Plus
when
cardiac arrhythmias.
I talked to my dad about it because it wasn't very like specific, and he was like, "Oh yeah, arrhythmias." I was like, "Oh, okay, that's good to know." I'm so glad the textbook went into that.
So glad I discussed that. But it is, I mean, they are good options because they're really good for this. What was the other class that y'all were talking about? Sulfonamides. So how many people are allergic to sulfonamides?
A lot of people.
Okay. So one of the big side effects, well, first, how does sulfonamides work?
It's suppressive. It's a bacteria.
They inhibit the synthesis of folic acid.
So the sulfonamide example, Bactrim is our best example, and this is probably what I would say is one of the most common ones. So I would say allergic reaction is up there on the list. What other side effects do you see with our sulfonamides?
See that?
No matter what, you're going to get the foods. Potentially. Because they're semi-broad spectrum.
Skin hyperkalemia.
Stephen Johnson. This one definitely can too. So, people can end up with recurrent UTIs, which is a problem because we don't want them on these antibiotics a lot. So it's just something we need to think about, preventing UTIs. So we said that good hygiene is one thing to prevent, right? So we've talked about hygiene. What else can prevent?
Go to the restroom more often.
What'd you say?
Go to the restroom more often, like
So-
every 3 or 4 hours.
So how can we go to the restroom more often? Drink more.
Take a shower, not a bath.
Frequent restroom. Drink more. Water. So shower.
Don't use all those little
Yeah.
No
No sense.
Avoid douches, I guess.
Yeah, no douching. Cranberry. So the thought with cranberry is that it acidifies your urine, which the bacteria don't like, and they won't grow as well. What about patients who are diabetic? We need to control their sugar because the bacteria like sugar. They feed off the sugar, and it'll get worse. So control diabetes, control sugar levels.
Urinate after sex.
That's a good one. Say AC and NHF. Okay. Now we need to do all these things because to prevent, because we know, like I said, that that the problem is that the complication of having bladder infections is that, which we know that, okay, cystitis, you know, that's, you know, causes this burning, pain, all these lower urinary tract symptoms that you're aware of, that it can move up into a pyelonephritis, right? Pyelonephritis now, it's more of a kidney infection or systemic, which can become more of a systemic infection. Now, if you've got a pyelonephritis or kidney infection, now what symptoms would you be having? So this back pain, right? What else? Chills, fever. Now, can you have whenever you have the bladder infection? You know, some people have can have fever, but a lot of times with the when they have you know, it's kind of like the telltale sign that you're going into a more systemic infection is that you start having fever with pyelonephritis because it's kind of become more systemic. Has anyone here had pyelonephritis before? Man. Yeah.
While I was pregnant.
Mm-hmm.
It was even worse.
Yeah. So what do we have to do for pyelonephritis? Yeah, definitely fluids and antibiotics. Because it's fluids and antibiotics is definitely a mainstay. These patients can be hospitalized because of the pain that they're having. You know, some with milder symptoms we can treat at home just with over-the-counter antibiotics, or not over-the-counter antibiotics, antibiotics at home and over-the-counter pain medicines. But a lot of times we end up having to hospitalize them. We've got to treat pyelonephritis pretty aggressively because we don't want it to turn into where they end up with like kidney damage because of the pyelonephritis. So antibiotics they need to be on, and also the NSAIDs are a good pain reliever, and also that Azo or that medication we had up in our quiz. Okay. See if there's anything else we want to talk about here. Oh, one thing that I didn't mention that they can end up with pyelonephritis with that systemic, and they can start having some like nausea and vomiting also. So that might be a sign that it's moved up more systemically. All right. So let's talk a little about obstructions and calculi.
Wait, real quick, did I say to douche or not to douche?
No douching. I should put in no douche. Don't do it. Okay. So calculi. So most it says here most substances such as most calculi are calcium oxalate, calcium phosphate, and uric acid. But there's a good table in your book that describe all the different types of stones that are formed and how to prevent them. And that is kind of a good source of information. This is interesting that most of your kidney stones, we finally have hit something that is more common in men, sort of like the cardiac stuff. We've been on women for a while with all the autoimmune stuff, so now we're kind of back to the men. So kidney stones are more common in men than women, except for struvite. So struvite is a type of stone that's more common in women. So we said calcium oxalate, calcium or uric acid. Struvite is another type of stone. What do you think causes struvite stones? What'd you say?
Estrogen?
UTIs. So UTIs. The way I remember it is, again, dumb, but there's a U and a T and an I somewhere in that word. It might not be in the right order. but there it is. A UT and an I is in that word, struvite. So struvite stones are caused by UTIs. And so more UTIs are found in women. Therefore, that's why struvite stones are more common in women. Also, they tend to have family history, and they tend to recur. So it's kind of a big deal, the recurrence, because you get them once, you're going to tend to get them again. Also in the summer months and in the southeast and southwest of the U.S. Why is that? You get dehydrated. And so dehydration is a really, really big problem for these people. Now, have y'all heard of the term urolithiasis before? Urolithiasis. Yes. So urolithiasis, that's the word for stones in your urinary tract. Whereas if you see the word nephrolithiasis, that's the stones in the kidney. And so urolithiasis, it's just kind of, okay, you got a stone, it's in the urinary tract somewhere. So you'll hear that word a lot, like urolithiasis. And that's just that we know that you have a stone somewhere. And so that terminology you kind of have to be familiar with. Now, this is where stones tend to get obstructed and stuck in your system. And that's a lot of times it's because that's where there's some areas of narrowing or areas of junctions. And so you see there that there's some issues here in your renal pelvis, issues in your ureter, or there at your ureterovesical junction. Also, you can have problems here like in your urethra. And so it's kind of like a couple different spots that the stones can get lodged. And that's where you can have a lot of spasms and pain whenever they get lodged. Man, these people get really sick. They're miserable. Miserable. Like nauseated, vomiting, throwing up their toenails, sick, in so much pain when these stones are moving. So whenever you look at what causes them, it's really important to know what causes them, because remember, we're trying to prevent them from happening. So you've got to look at the different sources. And you kind of break up these sources into the metabolic, dietary, genetic, and that's what we're really trying to sort of target. Dietary tends to cause a lot of them, and we've already talked a little bit about the uric acid stones, and that we need to prevent, get people to sort of lay low on the liver and the purines. But there's also those stones that are like the calcium oxalate, and so we need to start adding the foods that are high in oxalate on our list of foods that we need to avoid. So there's another list for you to make, foods that are high in oxalate, which chocolate is on that list too. I know. So, but one of the biggest contributors is not drinking enough fluids, because what happens is that these little crystals form, and if you're drinking enough fluids, then you sort of just flush them out right before they form little crystals and can solidify and make a mass. And if you're not drinking enough fluids, that's what happens. They form little like crystals in a mass, and now you get a stone. So those are sort of things you got to watch for. Now, if you've got a genetic tendency for these, then these people are those that have this like recessive disorder, and there's tend to form these cystine stones. And well, unfortunately, not a ton you can do about that except just drink a lot of water and try to keep them flushed out. But there are people who have those genetic tendencies. And lifestyle, we talked about those people who live in the southern climates, or maybe you work outdoors and so you stay dehydrated, or maybe you're a nurse and never drink or pee or anything like that. But you know, you think about those people who that's maybe their lifestyles, that they have a tendency to not drink a lot of water, or they're just high risk for stones because of that. So let's see.
It's like sedentary lifestyle, is that like a cause to, could that be?
Yeah, it definitely could be, because it's
Just in its, like,
probably,
indirectly.
yeah, probably not, you know, crystals could probably form because of that too, little crystals. Mm-hmm. Okay, let me see. So this is just sort of the pathophysiology of it. I'll let y'all look at it here. The only thing that I'll point out is that some of the stones are dependent upon the urinary pH. So, sometimes you can manipulate the pH a little bit, and that will help you prevent the stones. So like calcium and phosphate stones, you can actually kind of manipulate the pH a little bit, because the higher the pH, the less soluble calcium phosphate, the lower the pH, the less soluble are uric acid and cysteine. And so you can kind of use that to your advantage a little bit. But let's see. Otherwise, let me see. Oh, yeah, this is obstruction. That's like, if you think about people who have Foley catheters, that might be a contributing factor. And we've got a lot of people in the hospital that might have a lot of like really ill people. And especially they might end up with these infected stones because they get UTIs a lot. That's one of the big causes of UTIs also, which we didn't talk about. And I could put up here as one of the preventative things is like just the idea of Foley catheters cause it. So not having Foley's or taking out Foley's as soon as possible, it goes for both of these. So here's the list of types of stones. So the calcium phosphate and calcium oxalate, uric acid, cysteine, and struvite. And struvite is a magnesium ammonium phosphate stone, but it's caused by UTIs. This is interesting cross-section of a kidney, but you see right here where the renal pelvis is actually really dilated because of a stone being stuck in there. And you kind of see a size of a stone right there, and places where it can get lodged. One of the terms that you might hear sometime as far as a clinical manifestation is renal colic. So I'll point that one out. And so renal colic is this pain that people feel, and it's because you do actually have peristalsis in the ureters. And as the stones are passing through the ureters, the patients are going to feel pain. And so you'll hear that term sometimes, renal colic. Think about that.
What's that pain like?
Yep, they'll say, I was going to say stabbing is what people will say it feels like. Sharp stabbing.
Period on steroids.
There you go. Period on steroids. I like it.
Can you have a kidney stone, but just like the only symptom being like burning upon urination?
I don't know if I've ever heard anyone that, I mean, I guess potentially. Yeah, maybe. I mean, like you see here, most of the pain is like you've got, you know, it starts with like a flank pain, and then you've got all this other stuff accompanying it with it. But, you know, a lot of times you do end up with these lower urinary tract symptoms. So that would be the pain upon urination.
Because I had like one little stone one time before, and the only thing I had was like
Was painful. Yeah. So maybe you tolerate pain really, really well. Just say that. But yeah, maybe it was a small enough stone, like you were able to pass it without any problem. But yeah, a lot of times also you do have some hematuria because there's damage as it's moving, damage as it goes. Lots of ways that you can diagnose the stone, as you see, and as we've talked about some of those. But it is really important to figure out what that stone is, and that's what we were talking about with the retrieval and analysis and the guy keeping his stones clanging around there. So we could figure it out, because we got to know what it is so we can figure out, you know, whether we say don't eat this, do eat that, or if we try to give you some sort of something to prevent it from happening. So the management of the attack, what do you think we'd be giving these people in the acute attack phase? Pain medicine. What kind of pain medicine? Like Tylenol? Morphine. Like morphine. Like morphine and Zofran and promethazine and fluids, because they're not going to be able to keep anything down. They're going to be pretty miserable. So, yeah, absolutely. They're going to be pretty miserable. Now, hydration-wise, when we're talking about preventing them from getting stones, how much do we want them to be drinking? 2,000 to 3,000 milliliters a day. And now we're talking if this is a person who can tolerate. Now, don't go telling your CHF patient to drink 2,000 to 3,000 milliliters a day. But if they're, you know, healthy otherwise, to prevent. Yeah, that's right. To prevent renal calculi, make it where you can't breathe.
I find that people can actually track it better when you tell them to drink half your body weight in ounces. Because someone who's only 100 pounds versus someone who's 250 pounds, it's a big difference with the amount of liquid. It
is. Now, is that going to be hydrating them? Like, we want them to be like really super overhydrated. So is that like super overhydrating?
It is.
Half body weight?
It's very hard.
I was about to say, I don't know if I could.
I've done
it's
that.
A lot.
I'm with her. That's what
I always tell people.
That's a lot.
On my boot camp, you know. That's how much you should be drinking.
Half your body weight ounces.
And it actually references it on page 1037 also.
The half the body weight?
Yeah, for a UTI. So I think it's interesting that they're saying it there, that, and then a few pages later they say, no, tell them 2 to 3 liters. So,
yeah.
I've done what she's talking about.
It's a lot of water. It is.
Well, I used to carry around a gallon.
I don't know if I could drink that much water. I'd be floating. I guess I'd let y'all have more water, more pee breaks. Yeah. Yeah, for sure would let you have more pee breaks. Now, if the stone's too big to pass yourself, what do we have to do? Lithotripsy is that one, we prefer lithotripsy over some things because lithotripsy we can actually, it can tend to be a little bit less invasive than some things. So lithotripsy is where we can, we've got right here, is where, oopsies, go in and we can use shock waves to actually like pulverize the stone, and then you can just kind of pass the sandy stone.
Oh, I saw that
stuff. Did you?
in the OR.
Oh, very cool.
You can actually see it being like, yeah,
blasted, sandblasted. Now, how did they do it?
Well, he like
got to somebody like shocked it and it like went into little pieces and then they like
pulled it out.
Because I guess it was too big to pull out together.
Did they? How did they go in? Did they go in through?
Yeah.
Through the urethra to shock it. So there's multiple different ways they can do lithotripsy. Like I think I've got like one of the old timey pictures here. Look at that. That's how they used to do it.
Well, why did we have to wear glasses? Like, because they said we had to protect our eyes too because of the like.
Because of the shock waves.
Yeah, but it's like inside. I mean.
I'm sure because of the pressure or the. Yeah, because they used to have to do it like this. This was in water.
Why in water? Oh.
Because of the waves. Yeah. See.
And it looked like it was bouncing around.
Yeah.
You
feel it?
She's like smiling.
Yeah, she's all like, "No, this is going to be great." It was probably a hot tub, you know. Anyways.
Do you are you asleep? Do you feel that? Do they do it while they're awake?
For that, no. I mean, that person was awake, but this person's asleep because they're doing it with a cystoscopy, and that's one of the cystoscopic lithotripsies. Yes, and that's so an endourological procedure where they're actually going in and shocking it. So there's plenty of different ways that they can go in and, remove the stone and pull it out. And there are times where it's too big or it's in a spot that they can't do that, so they can go in and actually remove the stone with all of these different open surgical removals. Now, we're concerned always that the patient's kidneys are going to be damaged with these stones. And so that's something that we have to be, that we have to be watching, or is kidney function following. We've talked about these before. Look at that, there's a list of purines and things high in calcium oxalate on here for you. Nursing diagnosis, some nursing implementations. So we talked about the fact that they need to drink up to about 3,000 milliliters a day. One of the things that we can see that they're hydrated enough is if they're producing at least 2 liters of urine a day. So there's a good way to at least see if they're hydrated enough. So you're getting at least 2 liters of urine a day. This is interesting. It's something I hadn't necessarily thought about before teaching this, but mobilizing client as soon as possible and as much as possible to prevent stasis of urine and reabsorption of calcium from bone. So reabsorption of calcium from bone. So knowing that movement helps deposit calcium back into the bone. And I'm like, that's true, and I hadn't thought of that. So something to think about and teach patients. And then we can also self-monitor urine pH for those different types of stones that are, pH dependent. So we can, if they need to kind of keep their urine pH in a specific range to keep those stones from forming, they can monitor their pH at home. I think we've talked about all of those things. BPH, just a few things there we need to talk about, but what mostly need to say is that right here, you've got, not you, men, I guess I can't just say in general you, men have a prostate surrounding their urethra that tends to become a problem as they get older. And this prostate, the problem that they tend to have is that it gets bigger. And the bigness becomes a problem because it's surrounding their urethra. And then they get to this point where it just becomes a problem. The way, let me get to my, this is a good picture of it here, of the prostate. This is the development of how it gets bigger. I think this is a really good picture of it, like of the pathophysiology, but it's sort of stimulated by testosterone and their testosterone levels. There's the clinical manifestations here, but I like this picture because it really helps us see it. So they can start, because of the size of the prostate, they can start getting this interruption in the urinary stream. And I think about all the little men that I've had in, that I've tried to help to go to the bathroom. And, you know, I think that this is going to take 2 seconds, and really it takes 30 minutes. Because it's not a short process, because I'm like, okay, well, here's your urinal. And they're like, no, I must stand up. And I'm like, okay. And that's a you know, but it makes sense because this is, you know, prostate's too big to allow them to be able to go to the bathroom lying down. And so, and then they'll start peeing, and I'm like, okay, well, they're done. And then they're like, nope, a little bit more, and a little bit more, you know. And this is what's happening is, so they'll have some interruption in the urinary stream and a little hesitation before they begin to urinate, because, you know, you'll sit there and you're like, well, maybe they didn't need to go. Oh no, there it comes, you know, and that's what's going on. And then the terminal dribbling, and that's where you think they're done, and nope, like 5 minutes later, it's still just a little bit more, a couple more drops. And the urgent need to urinate, and that's the I gotta go right now. And the weak urinary stream, and that is very true. You know, they used to be able to, you know, hit the ball, and now they're having to stand really close to the urinal. And the frequent urination, especially at night, they'll get to the point where they like can't sleep at night because they're constantly going to the bathroom. And they're tired all the time because they're constantly going to the bathroom. So this is like, I mean, it's a big problem for older men. It really becomes a problem. And it is really more prevalent than you think. So it's something that we have to be aware of. How do men know, I mean, how do we diagnose BPH? So, and how many people think that their dad or grandpa are going to go get their digital rectal exams? Which digital does not mean numbers. Digital means digital. So digital, we're going to, you know, the doctor's going to check by putting their finger up the anus, because that's the closest place to check and feel to see if the prostate's enlarged. And what they're checking to see is if it's enlarged and smooth, then that's an enlarged benign prostatic hyperplasia. If it's enlarged and bumpy, or if they can feel a nodule, that might be prostate cancer, and we might have to go get a biopsy. Also, they can do a PSA, which is a prostate-specific antigen, and see if it's elevated, and that could indicate either BPH or prostate cancer also. So that would just be another indicator if they need to get a biopsy or not. Some of the issues with someone having BPH. So some of it is that they could end up with it being completely obstructed. The urethra being completely obstructed. Now, some of us have gotten to put in Foley catheters in men. It's not the easiest task, right? And especially in older men, because sometimes there's a prostate there that just, you can't get it in. There's been some men that actually end up with suprapubic catheters, which are catheters that go from the abdominal wall straight into the bladder because their prostate's too large. Those are safer than having them through the urethra for long term. So they end up with suprapubic catheters because their prostate's too large. And maybe they weren't candidates for more invasive surgery to decrease the size of their prostate. and pharmacological management didn't help. So they just now have a catheter for life. Because if we have urinary obstruction and that urine starts backing up, now we're talking kidney failure. They're going to go into kidney failure. So we can do surgery to decrease the size of their prostate. So anyone know about that type of surgery? So it's, yeah, transurethral resection of the prostate. So it's called a TURP. You have transurethral resection of the prostate. And, let's see.
I think it's longer time in the hospital, but the results are good.
So now we can do it robotically, and they don't have to stay quite as long. I used to, these were kind of fun patients for me, not because they were on continuous bladder irrigation, which I always enjoyed. I thought it was one of those like challenges. I was, challenge accepted. But they would go in through the urethra, and they would essentially kind of roto-rooter out the prostate. But these patients have a tendency to bleed a lot and cause a lot of clots, and that would plug up the whole urinary tract. So we have to put in a large urinary catheter that would that's going to flush out all those clots and keep them from clotting off. And so that's what this is, a triple lumen like Foley catheter. It's got 3 different lumens, and one is for bladder irrigation. And sorry, I'm flipping around looking on it. So these patients can bleed on you a bit. We still do TURPs, fairly frequently. Like I said, if medical management doesn't work, like pharmacological management. Whenever you have a patient who has continuous bladder irrigation, you'll see it written as like CBI, continuous bladder irrigation, and they've got one of these catheters in. One of these is going to be to drain, right, to a drainage bag. One of them is going to be to the balloon to keep it in. And then one of them is going to be up to a bag that has fluid, whether it's saline or sterile water. And we're going to drip in the sterile water as fast as it takes for us to have usually like a light pink drainage. And that's up to us. The doctors will, they don't say 50 drops per minute or anything like that. We drip it in to keep that urine looking pinkish. Like, we expect it to be pinkish. That's the color it's going to be. What we don't want it to be is reddish. Reddish is too bloody, so I need to speed it up. Now, I don't want it to go so fast that I'm going to have to be emptying that Foley bag every 30 minutes. I'll tell you, this is how I found out how much a Foley bag can hold. It's way more than it says. It can hold like 3,000. Because I'll walk in like 45 minutes later because I got busy with another patient, and it was like, it's going to explode. Yeah, you want to drip it in just to keep that looking like a nice pink color. And they usually keep them on irrigation for like 24 hours just to keep that nice and clear. They can do other things like an open prostatectomy, but that's going to be much more invasive. Now, the different drugs that you can put these patients on. You probably have had patients on potentially finasteride, which is a alpha reductase inhibitor. and also probably tamoxifen, Flomax. Those are the most common ones. So those are to reduce the size of the prostate and let them go to the bathroom easier. I like, Flomax is easy one to remember. So, like it says up there, ProScar's got an issue with women who may or may be pregnant, should not handle that because it can affect. It's got where it can cause birth defects because it affects the testosterone production. So if you happen to be pregnant with a boy, it could affect and cause birth defects and because of that. Oh look, there's continuous bladder irrigation. Let's see. We've already talked about pyelonephritis. So the last thing here that I want to mention is about urinary diversions. And I don't usually talk a lot about urinary diversions. I just want you to be sort of aware of them. But some people have to have, like if they have cancer, they have to have their bladder removed, like totally taken out. And we have to come up with somewhere for that urine to go. And we had a patient one time at St. Joe's when I was doing clinical there. She was really cool. She had her bladder removed, and she had, we would catheterize her through her belly button. And she, it was a continent diversion, which means that she wouldn't, it wouldn't leak unless she would let it go too long. But she would just get a tube and catheterize and let it drain, and she was good to go, right? So whenever we're talking about urinary diversions, the biggest thing is to decide, is it a continent or an incontinent diversion? So what's the difference between the two? So say we have an incontinent urinary diversion.
Where it's like a bag.
So just like a colostomy bag, now we're talking urostomy bag. Now we've had a patient recently, right?
Mine.
Yeah, who had a urostomy bag. So can't control, it's just draining. Can't control, can't say stop, right? It's just draining. So a whole new set of teaching things we have to do for someone who has an incontinent diversion versus someone who has a continent diversion. So let's look at these incontinent diversions. So one thing that I want to point out is these incontinent diversions, you see that these end with the word conduit. So we have ileoconduit, colon conduit. You see over here, all these continent diversions, they end with the word pouch. So cock pouch, man's pouch, Indiana pouch, Florida pouch. So that's how you need to remember for these diversions, okay? Because again, the teaching needs are extraordinarily different. So in continent diversions, they're going to use some piece, usually of like the intestines, to that they take out the bladder. They'll stick the ureters into some part of the intestines, because the intestines is pretty impermeable, and then they'll bring that up to the skin to make a stoma. And then we're going to have to put a urostomy bag. But again, like when we go to change that urostomy bag, it's just going to drain, and we're going to have to keep that skin nice and clean and prevent skin breakdown. So an ileoconduit, they use as part of the ileum. Colon conduit, used as part of the colon.
So the colon conduit is just like use part of the colon to make inside the bladder. It's not like your poop's coming out there too.
Right. Yeah. Sometimes they can go straight into the like depending upon like what type of diversions, but for most of your most of your urinary diversions, they're not going to want to do that because they don't want to introduce any bacteria, if that makes sense. So they want to keep this system separate. So for some diversions, not urinary diversions, they would do that. But this, they're going to want to keep this separate. They would like actually take out a piece and use it separately.
So they take out a piece, reconnect, use that
Reanastomose.
separately, and then, okay.
Yeah. Okay, continent diversions, you've got a degree of control. You don't need an appliance. You may or may not have a stoma. So like the lady I was talking about that had the one that was through her belly button, that's a stoma, but it's a continent diversion. Because it was a stoma, it was a formed spot. It's just that it was a continent diversion because it had a sphincter of some description that kept things from coming out. Here's some examples here of the cock pouch where you've got a stoma where you have a intussusceptive portion of this, which means it's like brought back into itself, where the ureters are implanted. And there's a bunch of pictures in your book that you can look at the different types. I won't get into the nitty-gritty of the different types because it's not that big of a deal. Like this one, they actually have gone into a couple parts of where this one actually the urine does pass into the stool. They don't really use that one anymore because of the infection piece of it. Now, this is a very cool type called a neobladder. And this they like to use a lot because, well, this is where they make a new bladder. Like they actually form a bladder. So they take out a piece of bowel and they make it look like a bladder and they stick it where the bladder was and they put the ureters into it. And if they were able to preserve the bladder neck, because maybe a lot of times they would do this because there's bladder cancer, right? And maybe if there wasn't cancer in the bladder neck and they were able to preserve that, which is where the sphincter is, and they just stick this on top of where the bladder sphincter was, then it acts just like the bladder and patient pees just like normal. And you would never know the difference.
And you can like regulate it?
Mm-hmm. Because they have the bladder neck still there.
Well, if they don't?
If they don't, then they would be incontinent.
Would it be like a catheter type thing? Or?
It just depends.
Can you get a bladder, what is it? Transplant? Can you transplant like all organs?
Probably could. Now,
yes.
Bladder. Okay, so a couple of things. We need to talk a wee bit about the studying how I want you to study for electrolytes. So you saw the different examples of questions you could have for electrolytes, and that's kind of the biggest thing that you need to practice is memorizing the signs and symptoms and practicing electrolyte type questions. So I'm going to open up some questions on ATI. I know you've got like electrolyte questions on, fluid electrolyte questions on adaptive quizzing, but I'm going to open up some like a practice like quiz. It's not like a grade quiz, but on ATI, and I'll give you the access and stuff for it. That will be some like, again, some more example of how like the electrolyte questions would be. So that will give you some practice on those. And that, I think, would be the best way to study for that. Do you remember the pharmacology table that you did for electrolytes way back when? If you didn't, I will. Huh?
Yeah, what she did was she had us write down 3 for each one, and she had that guy Mike, do that video.
Annoying Mike, yes. I can pull that back out too, because having some sort of table like that where you've got signs and symptoms, compare and contrast, and having the what the value should be, knowing the signs and symptoms for hypo and hyper, and also being able to look at which one's a weakness, which one for like hypocalcemia, we know is tetany. Well, we just in hyperkalemia is more of the muscle like spasms. So if we can kind of compare and look at all that on one piece of paper and have it on one piece of paper and then answer some questions, that's going to get you where you need to be. So I'm going to open up the this ATI quiz that has a bunch of questions for electrolytes, and then we're going to do a exam review on Tuesday or Wednesday, which we're about to vote. Oh, Monday or Tuesday, which we're about to vote. And then we'll go over those quiz questions. Sound good? From this ATI practice quiz that y'all will take between now and then. And that will get you where you need to be on those electrolytes. Yeah?
Do you want us to still do the responses for that?
And responses, you don't have to do. Okay? But feel free to look at your friends, what your friends said, because, they're so smart. So, exam 4 review. It's going to be at 8 o'clock no matter what, because that's the time that I can do it. So, 8 o'clock Monday, raise your hand. 1, 2, 3.
What if you don't care? Do you have to vote?
Tuesday, sure.
2, 4, 6. Someone else needs to count. Okay, what about on Tuesday?
Why Tuesday? Well, we have our mental health. We just have our mental health test, so then you could, if you're behind in that.
Which I am.
Monday is still sort of winning out.
I'm like, I would like to hear why I should go.
I said probably we can go okay, get all nurse and sleep. We'll be at the hospital this weekend, so we got to study for the 21.
But you can still watch it afterwards.
Yeah. So we have the nutrition presentation due Monday, and then mental health test Monday or Tuesday, and then adult health test. People have rock prayer Wednesday.
Okay. You're like, I'm leaving.
I'm definitely going to